afternoon, everyone. Thank you to the organizing committee for inviting me, especially Jyoti Bajpal, who started getting in touch with me more than 6 months ago. I have 8 minutes to talk about the demographics of breast cancer in Singapore and to give an overview of the management of triple-negative breast cancer at the National Cancer Centre of Singapore. Singapore is a small and compact country with a population of 5.7 million and a land area of 728 square kilometers. It has good roads and it takes 40 minutes to travel from the westernmost point to the easternmost point by car. There are 3 public healthcare clusters. Each is a conglomerate of general hospitals, specialty centers, community hospitals that provide step-down care, and polyclinics, which are primary care clinics physically grouped together. For the average Singaporean, treatment is paid for from different sources. MediShield Life, which is national health insurance and its claim limits. MediSave, which is each individual's enforced savings and has a cap to the monthly deductible amount. And a few financial aid schemes, MediFund being one of them. The ethnic makeup in Singapore consists of 76% who are Chinese, 15% Malay, 7% Indian. The Singapore Cancer Registry has been keeping records since 1968, and it shows a 4 times rise in breast cancer incidence over the decades, with the age standardized incidence rate having increased from 20.1 to 70.7 per 100,000 population. In the 5-year period from 2014 to 2018, there were 11,232 new breast cancers, averaging 2,246 per year. This constitutes 29.3% of all cancers. In the majority of cases, the stage at presentation was early, with stage 1 at 37.5% and stage 2 at 35.6%. Locally advanced made up 16.1% and stage 4, 10.8%. There were 2,196 breast cancer deaths in the same 5-year period, averaging 439 deaths per year, making up 17.3% of all cancer deaths. The age standardized mortality rate is 12.6 per 100,000. Breast cancer is of the highest incidence of all cancers in the 3 main ethnic groups. In the Chinese, it took up 28.8%, 29.5% in the Malays, and edging over the 30% mark are the Indians with 34.5%. By age, breast cancer takes top spot in the age group 30 to 79. The National Cancer Centre of Singapore is part of the SingHealth Healthcare Cluster. Together with other SingHealth hospitals, a joint breast cancer registry was set up, which has been collecting data since the 1980s. The most recent update showed data up to 2019 with more than 26,000 cases. HER2 data was available from 2006 onwards. Looking at the histological subtypes, 12% were triple negative, 10% were ER/PR negative HER2 positive, 60% were ER/PR positive HER2 negative, and 18% were ER/PR positive HER2 positive. By stage, triple negative accounted for 10%, 14%, 13%, and 12% in stage 1, 2, 3, and 4, respectively. By ethnicity, it constituted 12%, 12%, and 16% in the Chinese, Malay, and Indians, respectively. So, a slightly higher percentage in the Indians. By age, you can see that the proportion of triple negative cases decreases and stabilizes as age increases. It starts off as 24% in the under 30s, then 16% in the 30s, and 11 to 12% from the 40s onwards. So that was a summary glance at the demographics of breast cancer in Singapore. Now we turn to an overview of the management of triple-negative breast cancer at the National Cancer Centre of Singapore. We start with a biopsy of the breast lump that had been detected either clinically by palpation or symptoms or radiographically. The axillary lymph nodes are also biopsied if they are palpable or enlarged radiographically. The tissue samples are sent to the histology lab to confirm the presence of carcinoma cells and to assess the ER, PR, and HER2 status. If the staging scans show the presence of distant metastases, the treating medical oncologist may call the lab to add on tests, for example, PD-L1, for the combined positive score. If there are no distant metastases and the histology report shows triple negative, then if the tumor is more than 2 centimeters in size or lymph nodes are positive, this patient would be seeing the medical oncologist for neoadjuvant or preoperative chemotherapy, as well as having a discussion with the breast surgeon as to what type of surgery is being aimed for. If it's breast-conserving surgery, then a clip insertion is done. If it's a mastectomy with reconstruction, then a consultation with plastics is organized. Meanwhile, a genetic counseling appointment is made to discuss germline gene panel testing, with a view to incorporating risk-reducing surgery in the overall treatment plan, as well as suitability for PARP inhibition in the adjuvant setting. If the patient is young, fertility preservation is also discussed, and an appointment with a gynecological fertility team is made. From the SingHealth Joint Breast Cancer Registry, we see that the proportion of patients receiving neoadjuvant treatment had been increasing in recent years, reaching nearly a quarter. Of course, these neoadjuvant patients include those who are HER2 positive. Same as everyone else, we tend to give both an anthracycline and a taxane in the neoadjuvant setting. A favorite is AC times 4, followed by weekly paclitaxel times 12, or the taxane first, then the anthracycline. Keynote 522 showed us that pembrolizumab used neoadjuvantly benefited patients regardless of PD-L1 or CPS status. In Singapore, it's a hefty 6,000 Singapore dollars for a 100 milligram dose of pembrolizumab. If used according to Keynote 522, it would be a staggering $204,000 bill. As you might expect, this is not easily affordable. For patients who did not achieve PCR, capecitabine is given. For those who are germline BRCA mutation positive, they are offered olaparib, which is a sizable $60,000 bill. For metastatic triple-negative breast cancer, we look to see if we have a clinical trial that is open and suitable. This is strongly encouraged. The menu of clinical trials consists of pharma-sponsored as well as investigator-initiated studies. And with that, I end here. Thank you.